and today I'll be discussing a critical issue in psychiatric care: how we can reduce the use of physical and chemical restraints in patients experiencing acute mental health crises. This topic matters because excessive or inappropriate restraint use has a long-term physical and psychological consequences for both patients and staff. It can harm therapeutic relationships, increase trauma, and lead to staff burnout, according to Gaines et al. 2017. One of the most effective interdisciplinary strategies to reduce restraints is structured verbal de-escalation training. When consistently applied, this technique can diffuse agitation, re-establish trust, create time for therapeutic redirection, according to Richmond et al. 2012. Key team members involved in implementation include psychiatric nurses, social workers, psychiatric technicians, and mental health providers, all trained to apply trauma-informed approaches during patient escalations. Evidence strongly supports de-escalation as frontline intervention to reduce aggression and prevent restraint use. In fact, a systematic review by Gaines et al. 2017 concluded that verbal strategies paired with structured teamwork are more effective than restraint in managing acute agitation. Another study by Kilofiga et al. 2022 find that psychiatric units implementing structured de-escalation programs saw significantly fewer incidences of aggression and coercion. In short, the proposed strategy will be implemented in 3 phases over 12 weeks. Phase 1 will be assessing staff knowledge and attitude towards restraint practices via anonymous surveys. Phase 2 includes conducting 2-week intensive training using evidence-based resources on trauma-informed care, nonverbal communication, situational awareness, and active listening, according to Richmond et al. 2012. And then Phase 3, role-play simulations with direct coaching and feedback. Each unit will identify de-escalation champions to mentor peers and reinforce accountability. This implementation model is supported by the American Psychiatric Nurses Association, which recommends ongoing coaching and role modeling for long-term restraint reduction. To evaluate success, we'll track the frequency and duration of restraints for 8 weeks post-training and compare it to baseline. We'll also collect staff feedback using pre- and post-surveys, conduct weekly debriefings after any restraint incidents, and host patient listening sessions to incorporate lived experiences. The goal is a 40% reduction in restraint use and improve staff confidence scores in de-escalation. To conclude with that, minimizing restraint isn't just a policy, it's a patient safety imperative grounded in ethics, trauma, recovery, and dignity. With clear training, interdisciplinary cooperation, and consistent follow-through, we can make psychiatric care safer for everyone. Thank you for watching. Here are the references used from my podcast.